I'm happy to make a presentation on proactive therapy with the triple drug FDC with a particular focus on evidence-based findings. I thank Dr. Vijayakumar for his kind invitation. Also thank the sponsors USP for their kind invitation. My disclosures, what I'm going to do for another 15 minutes. Type 2 diabetes is a multi-causal heterogeneous progressive renal hepatic metabolic condition. The progressive nature is one of the major challenges, so getting the patients to goal becomes challenging as the disease progresses. And ICMR in-depth study found that nearly 69% of the patients with the type 2 had not achieved the target goal of A1C. Early intensive therapeutic control has proven benefits in clinical outcomes. So the unmet need of improving A1C goal that is strongly associated with the requirement to diverse therapeutic options, namely for the individualization of care, what we call it personalized medicine. With this increased availability of therapeutic choices that may address various unmet priority needs. So the question of rational combinations in type 2 diabetes holds deeper and broader implications today. So South Indian phenotype. Yesterday, you must have seen Dr. Mohan. He made a presentation on South Indian phenotype. And South Indian type phenotype, the lessons learned. He has put one slide, what to do, right. So relevance of DPP-4 in Indians. This article was published by Dr. A.K. Singh. If you look into the total GLP, intact GLP, total GLP levels are very high. Intact GLP levels are very low. That means there is excessive degradation. So there is a progressive decrease in GLP-1 level as well as GLP-1 responsiveness as the patient moves from normal glucose tolerance to IGT to type 2 diabetes. Next is increased DPP-4 enzyme activity in obese patient. Again published by Dr. Anup Mishra. That is, the expression has been dysregulated in patients who are obese, type 2, having NAFLD and cardiovascular disease. Subclinical inflammation may be increased by DPP-4. So there is a need for us to prescribe DPP-4. If you look into this particular study, the glucose lowering efficacy of SGLT2 inhibitors and to a less extent DPP-4 was greater in studies of predominantly Asian ethnicity. So if you look into the evolving role of DPP-4 in Indian patients, so relevant DPP-4 inhibitor features: increases adiponectin level, improves insulin resistance, strengthens GLP-1 response after meal. With reference to SGLT2, increased adiponectin improves insulin resistance and favorable effect on weight as well as the lipid profile. If you look into the subgroup analysis from the EMPEREG outcome study, demonstrated consistent risk reduction for cardiovascular outcomes, mortality and renal outcomes with EMPA in Asian patients with type 2 and established cardiovascular disease. So intensive interventions to reduce glucotoxicity and preserve beta cell function. Instead of starting with the diet and monotherapy followed by stepwise treatment, escalation when failure is achieved. Early phase of type 2 intensive intervention reduce glucotoxicity. We can preserve the beta cell function. So there is a need for early intensification. We know the disadvantages with reference to step care approach compared to proactive approach, wherein we can achieve optimal levels of glycemic control within a shorter period of time, greatly reducing the risk for the diabetes-related complications. Why is timely combination therapy? It improves adherence rate, glycemic control, reduces medical expenditure, decreases the frequency of drug administration, and prevents polypharmacy. So many patients require more than one agent. So data from UKPDS, ADOPT study clearly shown the benefit that monotherapy may not be adequate enough to control effectively for a longer period of time. If you look into the metformin, how it acts, we know. Next is DPP-4 inhibitor. It raises the GLP level, reduces the glucotoxicity, and improves glycemic control. SGLT2 inhibitors induces glycosuria, reduces body weight with a favorable impact on lipid profile, and in the long run, it reduces the inflammation and oxidative stress. So triple power combination of builder, DAPA, and metformin. So let us take metformin. Works by helping to reduce the body's proper response to insulin sensitizer. If you look into this particular metformin-induced reductions in blood glucose, it suppresses gluconeogenesis, also raises the GLP-1 levels. Effect on metformin on mitochondrial function. It improves mitochondrial biogenesis and mitochondrial functions, especially with reference to autophagy. So the effect of metformin and mitophagy in type 2 diabetes. So multifaceted, Tasker, metformin reduces hepatic glucose production, increases fatty acid oxidation, increase in entry glucose extraction, improvement in peripheral insulin sensitivity, decrease in gut carbohydrate absorption, as well as enhanced release of GLP-1 and other gut peptides. So when you combine with the DPP-4, it enhances the GLP and GIP responses. Besides, it also raises the GLP level through multifactorial actions. So metformin, extending care in diabetes continuum as a first choice in patients with the pre-diabetes, newly diagnosed type 2 diabetes, established diabetes, type 2 diabetes with cardiorenal comorbidities, as well as elderly type 2 diabetes. So cardiovascular benefits of metformin, the features of UK prospective diabetes study demonstrated strikingly better macrovascular complications in those randomized to metformin versus conventional diet therapy. When metformin treated patients were compared directly to those on sulfonylurea or insulin, they experienced lower diabetes-related endpoints and less all-cause mortality and stroke. So metformin treatment is associated with improved outcome in patients with the diabetes and advanced heart failure also. So med treatment was independently associated with both better quality of life and improved outcomes in advanced heart failure with reduced ejection fraction patients with diabetes, provided the eGFR is adequate enough to prescribe as well as to continue metformin. So if you look into this particular verified trial, that is monotherapy versus early combination therapy, Builder and metformin. Patients on the metformin arm, 50% of the patients failed metformin at 1.5 years, Indian cohort, compared to international cohort, 3 years. So when started on metformin monotherapy, Indian patients tend to fail earlier, 1.5 years versus globally verified population, 3 years. So monotherapy may not be adequate enough for a long period. On the other hand, early combination therapy, 50% risk reduction in time to initial failure versus monotherapy. So patient initiated on this particular Builder metformin with the A1C of 6.5 to 7.5, they were able to maintain the glycemic status for a longer period of time, right? Next is starting early with Builder and metformin reduces the risk of addition of third agent. So the rescue therapy was less in the early combination therapy compared to patient on monotherapy with metformin. Next is DAPA, ACLT2 inhibitors. We know the mechanism of action. It acts on the proximal convoluted tubule, preventing the reabsorption of sodium and water. So these are all the benefits in terms of glycemic control, in terms of body weight improvement, in terms of BP, in terms of lipid improvement, cardiovascular outcome, renal outcome, so pleiotropic effect. So decletimi, patient with multiple risk factors and patients with established cardiovascular disease, when patients were randomized with reference to reduction of CVD, reduction of MACE, heart failure, hospitalization, secondary prevention population, all-cause mortality. So there is a place for us to prescribe both in patients with the multiple risk factors and patients with established cardiovascular disease. So comparing that DAPA patients, DAPA included in a particular study decletimi, wherein patients with multiple risk factors nearly 70% compared to patients with established cardiovascular disease nearly 30%. Next is DAPA heart failure study, clearly shown the benefit in terms of composite of cardiovascular disease, cardiovascular death as well as hospitalization for heart failure. Next is DELIVER study, that is patient with preserved ejection fraction failure, DAPA versus placebo. You can see the eligibility criteria. Again, there was reduction with reference to the composite of cardiovascular death as well as hospitalization for heart failure. So delivered study results, number of patients, centers, patient demographics, and results with reference to primary outcome, sustained more than 50% GGFR decline. Secondary outcomes with reference to cardiovascular death or hospitalization for heart failure and all-cause mortality. Next is with reference to vildagliptin. So increased DPP-4 enzyme activity. This I have already told. That is a study conducted by Anup Mishra. So patients with increased waist circumference, they carry increased risk for the very elevated levels of DPP-4 enzyme activity. If you look into the efficacy of DPP-4 inhibitors, it was higher in Asians than in non-Asians. So there is a definite role for us to prescribe both SGLT2 inhibitors plus DPP-4 enzyme inhibitor along with metformin. So vildagliptin, expanding horizons as first-line therapy in the elderly patient with the type 2, in long-standing diabetes, low risk of hypo as add-on to insulin, in obese patients, renal safety, cardiac safety, and less glycemic variability. With reference to renal CKD, we need to adjust the dosage. So vildagliptin as an add-on to insulin, when given, there was reduction in with reference to the dosage. So vildagliptin highest reduction in insulin dose as compared to other gliptins. It was more effective in reducing insulin requirement and achieving glycemic control when compared to other two. Next is demonstrating low hypo risk. Vildagliptin associated with the significantly fewer hypo episodes compared with the sulfonylurea therapy, good glycemic control as well as weight control observed in vilda treated patients. Next is islet enhancer vildagliptin with better TIR. In this particular study, patient in the vildagliptin arm, they were able to maintain for increased duration with reference to TIR. It produces dose-dependent reduction in DPP4 enzyme, resulting in persistent levels of active GLP and GIP in the circulation, leading to improved beta cell sensitivity to glucose and improved alpha cell sensitivity to glucose and reduction in inappropriate glucagon secretion. So it improves beta cell function, it improves alpha cell function. So patient with the diabetes type 2 have islet dysfunction rather than beta cell dysfunction alone. So recommendations from the guidelines. So IDF clinical practice recommendation, triple therapy with the 3 oral GLD, glucose lowering drugs, may be effective before adding an injectable. This was also highlighted by Dr. JSK. So recently SGLT2 inhibitors have been considered as an option to add on to metformin and DPP4 inhibitor, and RSSD guideline also recommends if glucose targets are not achieved with the 2 agents, start third oral agent, that is SGLT2 inhibitors, DPP4 inhibitors, depending on the second line agent used. If the patient is already on SGLT2, replace, you can add DPP4. If the patient is already on DPP4, please add SGLT2 inhibitor. American Association of Clinical Endocrinology, that is recommendations. Triple drug therapy can be used with A1C greater than 7. Their recommendation is when the A1C is greater than 7.5, initiate with the 2 drug therapy. When the patient has A1C more than 9, initiate the patient on triple therapy. Again, this will highlight A1C greater than 7.5, start 2 agents. Greater than 9 or more than 1.5% above the target goal, start the patient on 2 to 3 agents. So ADA, standard of care 2025. Again, the holistic person-centered approach to type 2 diabetes management. So because type 2 diabetes is a progressive disease, in many individuals, maintenance of glycemic targets often require combination therapy. There are data to support initial combination therapy for more rapid attainment of glycemic goals and later combination therapy for longer durability of glycemic effect. The choice of medication added to initial therapy that is based on the clinical characteristics of the individual and their preferences. And the recommendations for treatment intensification not meeting treatment goal should not be delayed. And incorporation of high glycemic efficacy therapies or therapies for cardiovascular and kidney disease risk reduction may reduce the need for agents that increase the risk of hypoglycemia and weight gain. If the patient is already on sulfonylurea, no problem. You can reduce the dose of sulfonylurea and add, or you can replace. And treatment intensification, de-intensification or modification as appropriate for patients not meeting individualized treatment goals should not be delayed. So combination therapy, combine drugs with complementary mechanism of action to help both pathophysiologic defects in diabetes. It improves glycemic control, offers greater efficacy, ensures safety profile, and reduces vascular complications, improves body weight and postprandial insulin, and associated with the reduced risk of hypoglycemia. So the key points: medication burden and adherence combination. Medication burden is high among individuals. There is growing evidence for the benefit of intensive treatment of risk factor early. So we put the patient on lipid lowering agent, blood pressure lowering agents right from the beginning. So patient might take 7 to 8 tablets. In addition, nephropathy treatment. Individuals with the diabetes are prescribed number of cardioprotective drugs, and there is a significant degree of multimorbidity and polypharmacy present in individuals with screen detected diabetes. So there is evidence that improved medication adherence may improve health related quality and guideline promote a multifaceted approach. So advantages of triple FDC therapy: improves drug adherence, act by different mechanism, effective glycemic control, reduces pill burden. So stage of diabetes, when this FD can be prescribed: at first presentation, treatment initiation in high risk patient, treatment intensification when previous treatment was inadequate to achieve glycemic control. And these are all the issues addressed with the triple FDC. So before I conclude, I request all our participants to register for RSSDA annual conference that is going to be conducted in Kochi on November 6 to 9. And yet another, we have Tamil Nadu chapter RSSDA track that is going to be conducted on 9th and 10th August, Coimbatore. I request all our participants, and of course today you can enjoy the benefit of discounted fee for registration, namely 1,500 rupees. From tomorrow onwards, it will become 5,000. Thank you very much for the kind listening.